I'll be talking about the complications of CLD. So this will be the content of my talk. So chronic liver disease per se, there will be progressive destruction and regeneration of the liver parenchyma leading to cirrhosis. But what we are worried about in our ICUs will be patients with decompensated liver disease where liver does not function adequately. So there are multiple complications of CLD. I will not be able to cover everything. I'll cover few things which are important from perspective of exams like variceal bleed, hepatic encephalopathy, hepatorenal syndrome, and spontaneous bacterial peritonitis if the time permits. And a few other things which we have to know about is hepatopulmonary syndrome, ascites, but I wouldn't be able to cover all that here. So variceal bleed, in a patient with cirrhosis, around 25 to 30% of the patients will have varices. Out of these, 5 to 15% of them will have bleeding. And the mortality is very high. 6-week mortality is found to be as high as 10 to 20% if the patient is having a variceal bleed. So, what is the pathophysiology of variceal bleed? So, in a patient with cirrhosis, we all know that there will be increase in the portal pressure. So, to bypass the liver, there will be collaterals which develop in different parts of the body. One of them is varices. So, these varices are usually very fragile and they are more prone to bleeding. So, this is what results in variceal bleed. So, as the stage of the liver failure progresses and size of the varix is big, then the risk of bleeding will be more in these patients. So, coming to the treatment of the variceal bleed, I'm sure everybody would have encountered patients with variceal bleeding. So, what we need to do initially is like airway management becomes important in these patients because the patient might be having a massive bout of hematemesis and they may not be protecting the airway. So, endotracheal intubation may be required. Then large bore cannula are required and initially we can give up to 1 liter of crystalloids, then followed by we'll have to, if it's a large bleed, if the patient is tachycardic, hypotensive, we'll have to activate the massive transfusion protocol and give blood and blood products. And if the patient has been on any anticoagulation, we need to reverse that as well. So initially there's a lot of bleeding, we might just without checking the hemoglobin, O negative blood needs to be given, but later on the transfusion trigger for these patients will be like 7, like below 7 we will be transfusing the patients, above 7 we are going to accept. But with ongoing bleeding it might be different. So this thing is antibiotic prophylaxis. So this is one of the reasons for empirical antibiotic therapy in the patient in ICU. So it is found that around 50% of the patients with variceal bleeding can have bacterial infections. And there are multiple studies, some meta-analysis which has shown that there can be some increase in the all-cause mortality and rebleeding chances more, length of stay in ICU may be more if you do not give antibiotics. So it is important to give empirical antibiotic in these patients. So which antibiotic to give? So in an ICU setting, we usually expect like child B or C class of liver disease patient. So we have to give ceftriaxone. Duration is 7 days. Quinolones also can be given in a more stable patient. In ICU, ceftriaxone is what we give. Coming to the correction of coagulopathy, so normal practice is to give FFPs or vitamin K based on the INR. But Dr. Buona has already mentioned this. So in a liver failure patient, what happens is not only procoagulant factors but anticoagulant factors also are deficient. So high INR will just give you the value of the procoagulants. So it doesn't really mean high INR patients will be bleeding. So TEG would be the ideal measurement what is required to look at the bleeding parameter. But what happens in everywhere TEG may not be available, the expense is more. So because of that, the common practice is to give FFPs if the INR is more than 1.5. There are some small studies which say that INR less than 1.5 if you give it might be harmful. Between 1 and 2 it is a little controversial. More than 2 they give, but ideally speaking TEG should be done before giving this FFP. Other things I have to remember, if the platelet count is less than 50,000, we do give platelet transfusion also. Then coming to the proton pump inhibitors. So initially, all the patients should be started on proton pump inhibitors. One thing is, even if we know the patient is a known case of CLD, in 30% of the patients with the varices, also the cause of bleeding can be peptic ulcer. So basically, even if you know the patient is CLD, we have to start them off on proton pump inhibitors. But after the endoscopy is done and you prove that the varices is the cause of bleed, we have to stop the proton pump inhibitors, because it is shown that there is some increased risk of complications like hepatic encephalopathy and bacterial infection and all that if we continue this proton pump inhibitor for a long time. But initially, do start it. Then coming to your frantic vasoconstrictors. So this is another patient with CLD comes with a bleed. Initially, start with the patient on terlipressin. So how it helps is, it will reduce the splanchnic blood flow and reduces the portal pressure, hence reduces the bleeding. So initially the dose of terlipressin recommended is 2 mg every 4th hourly for the first 48 hours, followed by 1 mg 4th hourly. So how long we give is, after an endoscopy is done and the varices is taken care of, we have to give it for a duration of 3 days after that. So the other splanchnic vasoconstrictors which can be used is somatostatin and octreotide. Then endoscopic therapy, this is the definitive therapy. So the recommendations say that it has to be done within 12 to 24 hours of presentation. So the best method is esophageal varicose ligation is the method which is used by our gastroenterologist to ligate. Sclerotherapy and hemostatic powder can also be applied. If endoscopic EVL fails, only then we go for sclerotherapy. So which varices do they ligate? So basically, if the patient is having an actively bleeding varices, that has to be ligated. Other than that, if you see a clot or you see a white nipple over the varix, they have to be ligated. Or if you don't find any other cause for bleeding, and then you can suspect maybe this varix is the one which is bleeding, and ligate that as well. So if the patient continues to bleed despite endoscopic procedure, then we can do what is called as TIPS, transjugular intrahepatic photosystemic shunt. So here the high pressure portal venous system is connected to the normal inferior vena cava system. So basically this causes shunting of the blood and reduces the portal pressures and reduces the variceal bleed. So this is done only if the endoscopy fails. And balloon tamponade is another thing using sensitive and Blakemore tube. So this can also be used if endoscopy fails, or in some centers if endoscopy is not available, we can use that. But patient's airway has to be secured before using this, and it can be used for a maximum of 24 hours. Other thing is self-expandable esophageal metal stent, which can be used if the patient is bleeding after endoscopy. They can be used for 7 to 14 days. I've never seen anybody using this. Okay, so that's about the variceal bleed. Now a little bit about hepatic encephalopathy. So hepatic encephalopathy, basically this neuropsychiatric abnormalities in a patient with liver disease. The main culprit here will be the ammonia. So ammonia, there's increased production of ammonia in the gut, and in a normal situation, liver will detoxify the ammonia into urea. But what happens in in a patient with cirrhosis is this function of the liver is limited. So because of that, there is ammonia accumulation. So this ammonia is neurotoxic directly, can cause swelling of the astrocytes. In addition to that, it will inhibit the synthesis of some other neurotransmitters like GABA, glutamate. So this also leads to neuronal dysfunction. And other than this, the chronic inflammation and oxidative stress due to the liver dysfunction itself can cause neuroinflammation. So these are the different mechanisms by which the hepatic encephalopathy sets in. So the diagnosis here will be mainly by history and examination. If the patient has flapping tremors or asterixis, that itself is quite diagnostic of hepatic encephalopathy. But if there is any diagnostic dilemma, then you can get a CT scan to rule out any other causes. Serum ammonia, like in chronic liver disease patients, there is you should not use it as a diagnostic modality. So because there are multiple fallacies, like one thing is In studies they have found that the value of ammonia actually does not correspond with the level of encephalopathy. The other thing is technically, like we've already discussed, it's difficult to get a correct value of arterial ammonia. So mainly it will be a diagnosis, like your diagnosis will be by history and examination. So West Haven criteria for grading hepatic encephalopathy, there are 4 grades you all will have to know. I'm not going to read through this now. So coming to the management of hepatic encephalopathy, so the main thing is to identify the precipitating factor. There will always be a precipitating factor. So you have to identify that and treat that. So common ones are like GI bleed, infection, electrolyte imbalances like hypokalemia. Constipation is very common. The patient might be coming with constipation. So it's important to take the history. Anything reversible has to be reversed first. So then supportive measures, patient encephalopathy might require intubation. Nutritional support, as per the recent guidelines for hepatic encephalopathy in a chronic liver failure patient, protein restriction is not recommended. 1.2 to 1.5 gram per kg per day is the protein which is advised for these patients. Then you might have to take care of the patient, like prevent falls. Haloperidol may be given to for the restlessness. So then specific medications. So in acute liver failure, there is no role for lactulose. Chronic liver failure, there is a role for lactulose. So how does this lactulose help? So basically, in the gut, lactulose gets converted into lactic acid and acetic acid. So this provides an acidic environment. So this will convert the ammonia into ammonia. So this ammonium ions, they don't get absorbed as much. So because of this, the ammonia absorption is reduced. So other mechanisms are like like increases the transit time, intestinal transit time, which itself reduces the ammonia level, and also the reduced pH itself will prevent the growth of urease producing bacteria. So here ammonia production will be reduced. So these are the different mechanisms by which lactulose helps in the reduction of ammonia. So dose, what we need to do is initially for the first, till the patient starts opening bowel, we might have to give ammonia, say 30 ml every second hourly. Then you adjust it so that you achieve a target of like 3 to 4 bowel motions per day. In patients who cannot take oral lactulose, we can give lactulose enzymes. Then rifaximin. So rifaximin, initially you don't have to start the patient on rifaximin. So in patient who cannot take lactulose, we can start. Otherwise, in a patient who does not have any improvement after 48 hours of treatment or after second hepatic encephalopathy episode, if the patient is having repeated episodes, then you can start rifaximin. Dose is 550 mg BD or 400 TID. There are other therapies like L-ornithine, L-aspartate, branchial amino acids, but there is no proper evidence for this. So initially only lactulose. Then if it's refractory, then rifampicin. So that's about hepatic encephalopathy. Then coming to the hepatorenal syndrome. So hepatorenal syndrome is another complication of cirrhosis. So basically it is a functional form of renal failure. So basically what happens is because of the reduction in the blood flow to the kidneys, there will be this hepatorenal syndrome. So previously it was like known as hepatorenal syndrome 1 or 2, but now we have another nomenclature. So that is hepatorenal HRS-AKI and HRS non-AKI. Okay, so there's criteria for that. So if the patients are not fitting into HRS-AKI criteria, then it is called HRS non-AKI, which also has HRS-AKD and CKD under that. So this is the criteria. So HRS-CKD when it's going on for more than 3 months. So the complete diagnostic criteria for HRS-AKI will be the patient should be having an underlying liver failure. It can be cirrhosis, acute liver failure, acute or chronic liver failure. In addition to that, there is serum creatinine which has to be more than 0.3 milligrams per deciliter. Increase more than 0.3 milligrams within 48 hours or more than 50% of the baseline value, or urine output less than 0.5 ml per kg body weight for more than 6 hours. And then you have to withdraw the diuretics, and if there is no response despite albumin administration, that's the other criteria. Absence of shock, absence of nephrotoxic drugs, and parenchymal renal disease has to be ruled out. So all this criteria has to be, this is a diagnostic criteria for HRS-AKI. So if it doesn't fit into this criteria, then it goes into HRS non-AKI. So pathophysiology, so what exactly happens here? So there will be reduced systemic vascular resistance in these patients, because you all know there is splanchnic vasodilatation. So this itself can reduce the renal blood flow. Also, there will be reduced effective arterial volume, like activation of renin-angiotensin-aldosterone system and sympathetic nervous system, which causes efferent arteriolar vasoconstriction, which further reduces the renal blood flow and causes HRS. So there are some other pathophysiology also, like circulatory dysfunction for whatever the causes, like cirrhotic cardiomyopathy can cause this, and systemic inflammation by bacterial translocation or by damaged hepatocytes which produce the inflammatory markers. So these are the other pathophysiologies. So management of HRS first will be to identify and treat the precipitating causes. So if any drugs the patient is on, that has to be stopped. Volume replacement should be adequate. If GI bleed, that should be corrected. Hemoglobin should be corrected. And then we have to administer albumin. So how albumin helps is, one is it is plasma volume expander. In addition to that, it has positive cardiac inotropic effects and anti-inflammatory effects as well. So dose of albumin will be 20% albumin should be given at a dose of 1 gram per kg per day for first 2 days. After that, 20 to 40 grams per day for maximum of 14 days. So this is the albumin which needs to be given. In addition to that, splanchnic vasoconstrictors I have already mentioned earlier. So for HRS, what we have to give is terlipressin can be given, or a combination of midodrine octreotide and or noradrenaline can be given. So in HRS CKD, usually we see refractory ascites, which is resistant to diuretics and there will be progressive renal failure. So the albumin terlipressin, there will be a high rate of recurrence in these patients. So here high volume paracentesis is what is indicated. In addition to that, TIPS can be done, and the definitive treatment will be renal replacement therapy, because this patient, definitive treatment will be liver transplantation. So to bridge the patient to liver transplantation, we can do a renal replacement therapy. So I will skip this because of lack of time, I think. So SBP is another thing which you need to know actually, but yeah. Anyways, the take-home message will be that for variceal bleeding, always remember the initial treatment will be to start the patient on proton pump inhibitors, give splanchnic vasoconstrictors, antibiotic has to be given, and endoscopy needs to be done. For hepatic encephalopathy, lactulose has to be given, and hepatorenal syndrome, albumin, and splanchnic vasoconstriction. So that is the end of my talk. Thank you.